Hello, my name is Neil Greenberg and I am a Professor of Defence Mental Health based at King's College London. I served in the Royal Navy in the UK for just less than 24 years, and I'm currently President of the UK Psychological Trauma Society. I'm going to speak to you today about how to prevent mental health problems related to military service using a very broad overview of how to prevent problems in terms of primary prevention, how to detect them at an early stage in terms of secondary prevention, and what one might do to try and treat problems, and therefore that's tertiary prevention. So to start off with, it's probably worth just outlining, certainly from the UK's point of view, what the main issues are for military personnel and veterans. And the first major issue actually is not post-traumatic stress disorder, which many people think, but in fact instead it's common mental health disorders such as depression and anxiety, and also alcohol misuse. We know in the UK that about 20% of serving personnel and veterans, and the figure's probably slightly higher for veterans and slightly lower for still serving, have common mental health disorders. This is comparable to the general population who's employed, but are probably about double the rate of the general population, including employed and unemployed people. We also know that the rates of alcohol misuse, and by this I mean scoring more than 16 on an audit questionnaire, which is using alcohol at a level that's likely to cause significant psychological, physical or social harm. And in the UK Armed Forces, about 13% of the Armed Forces report drinking at that level, and that compares to about 5% in the general population. But importantly, it's worth noting that alcohol misuse in particular does appear to be affected by deployment. So we know that about 11% of troops who haven't deployed in the last year misuse alcohol. That's an audit score greater than 16, and this compares with nearly 16% of troops who have deployed in the last year. So deployment does appear to increase the risk of alcohol misuse. But then moving on to post-traumatic stress disorder, we know that in the whole force, overall, about 4% of the force reports symptoms consistent with a diagnosis of post-traumatic stress disorder. And we know this is about the same in troops whether they deploy or not. We know that combat troops report higher rates, up to about 7%, and we know that reserve forces report rates of about 5%. So it is higher in reserves and combat troops. But really moving on to the main meat of the conversation today is what should be done to try and prevent mental health problems in a military population. So starting with primary prevention, that is the prevention of people suffering symptoms of distress at all, there's a number of techniques that have been tried. What appears to be really clear is that there is a highly important role for leadership in preventing mental health problems from occurring in the first place. Data that we've gathered on British troops deployed to Afghanistan in 2010 and 2011 has shown an incredibly strong effect for the powerful protective effects of good leadership. What do I mean by that? Well, good leadership as measured by our questionnaire includes officers or people in positions of responsibility not demeaning others in front of the unit, not taking on extra duties to make themselves look good at the expense of their team, treating all members of the unit fairly, and communicating information to the team in an effectively and timely manner. What we found in Afghanistan was that in troops deployed in 2010, the overall rate of post-traumatic stress disorder was about just less than 3%. However, in troops who reported that having good leadership, it was just over 0.5%, and in troops who reported having poor leadership, it was in excess of 6%. So there's a tenfold difference in terms of the deployed troops' mental health based upon how they perceive their leaders. Now, what that says is that the best bang for your buck is probably going to be making sure that your military leaders are particularly cognizant of the impact of their behaviours on other people. So I've mentioned the important effects of leadership in terms of making sure that troops' mental health are protected when they're deployed to challenging environment. And it's worth saying that within the UK Armed Forces, around 70% of troops report that their leader is a good one. Another important consideration is that of cohesion. So unit camaraderie, which is measured using questions such as would you be able to speak to other members of the team, would you trust them to treat your concerns confidentially and the like, is another important factor. And we know that troops who are able to rely on each other for their safety, but also for their emotional needs, are much less likely to suffer with mental distress symptoms in the first place. And it's perhaps a slight cheesy phrase, but it's true that within organisations, including the military and the emergency services, resilience often doesn't lie in individuals, it lies between individuals. Now, something else that's worth talking about at this stage is the important impact of training. And what we know is that in troops who are properly prepared for their job and also for deployment, the rates of mental health problems are much decreased. Now, one of the components of training before going away is about the delivery of a pre-deployment psychoeducational brief. And this brief would be given by either a trained peer practitioner within a unit or by a healthcare professional, perhaps a mental health care professional in some cases, but not always. And the brief would cover a broad outline of the sorts of psychological challenges that troops might face, how they can help themselves when they experience minor symptoms of distress, where they can seek additional help, and also how to look out for the signs of distress in colleagues. And we found that in a study done in Iraq and also in studies done in Afghanistan, that troops who reported having had a pre-deployment stress brief were far more likely to show psychological resilience, that is, not to suffer with mental health problems when they were deployed, compared to troops who didn't. Now, we controlled in our analyses for leadership because in the UK, certainly, troops should always have a pre-deployment brief, but we consistently find between 70 and 80% report having the briefs, leaving somewhere between 20 and 30% not having them. So it's possible that leaders who didn't make sure their troops received a brief also did other things that weren't going to help their subordinates. But actually, even when we controlled for leadership, the effect of a pre-deployment briefing on mental health still remained significant. There's also studies done in emergency services, some done, for instance, after the Madrid bombings of 2007. And what they found there was that in the terrorist police, who were the Spanish police who had spent a lot of time preparing for dealing with terrorism, you may well be aware that up until relatively recently, Spain had a big terrorist organisation called ETA, who caused an awful lot of mayhem and destruction in Spain. So these terrorist police were well trained and highly experienced. And after the Madrid bombings of 2007, when they dealt with the aftermath, their rates of psychological health disorder were tiny. Less than 1.5% of them, for instance, reported the symptoms of PTSD. So I think there's very good evidence that actually carrying out effective pre-deployment training, both practically and psychologically, is likely to have a positive effect on troops whilst they're deployed. Interestingly, one study we were able to do using our big cohort at King's College London didn't find a long-term effect of pre-deployment briefing. And by that we mean that some years after deployment, the effect of the briefing on longer-term mental health, it was insignificant. And if you can imagine, there's lots of things that will have gone on post-deployment over a period of years, that when you look back, the effect of a single brief before deployment then doesn't remain significant. Moving on to the interface between primary and secondary prevention, comes up with the topic of psychological screening. Now, prevention screening is screening with the intent to be able to weed out or select individuals who might have problems before they deploy, and therefore to remove them from the pool of deployed troops to increase overall force resilience. And there have been numerous studies done in the UK and also in Canada, which basically have shown pretty conclusively that actually the likelihood of you being able to correctly spot those who are going to have difficulties whilst deployed before they deploy is next to zero. When you look at why this might be, and as I say, these studies have involved many thousands of troops who have been subjected to good psychometric tests, looking for vulnerability to mental health problems, that when you look after deployment, that they're completely non-predictive of who finally did get problems. When you try and look why this is, if you split risk factors for developing post-deployment, post-traumatic stress disorder, and indeed other mental health problems, then you can split them into pre-deployment factors, deployment factors, and post-deployment factors. So pre-deployment screening might be able to look at issues such as gender, such as childhood adversity, such as a previous history of mental health problems. During deployment, you've got particularly the nature of the deployment itself. Was it a traumatic one? What sort of experiences did they see? And after deployment, you've got two main factors, which are how much social support the individual was able to access and how much stress or pressure they were put through in the recovery period. And you can imagine in military personnel, the recovery period has many potential stressors, with reuniting with families, with getting back to normal work, and in some cases maybe even coping with changes in job role or even health status. So when you group those risk factors into peri-deployment and post-deployment, consistently you find that the post-deployment, post-incident factors are by far the most predictive of longer-term mental health. So even if you are able to spot the relatively low impact risk factors before deployment or even before enlistment, removing them from the pool of deployed people does not really prevent overall the effects of deployment on mental health. So what this tells us is actually, rather than spending lots of time and effort in trying to screen out people who might be vulnerable to mental health problems when we can't do this effectively, that the evidence is that being able to make sure that troops who have come home are able to access informal social support in a good and effective manner, and also have a relatively lower stress or lower pressure period as they come home, is much more important. So there's good evidence that selection screening, certainly for military forces, is pretty much a waste of time. And the only way that this has been said to work was in a paper actually from the US military. And what they did, which is actually a practice that the UK does routinely anyway, and I suspect many other forces do as well, is to examine the medical notes of troops who were about to deploy to the Middle East before they went. And this was reported in a paper by Warner et al. And the design was that troops who were found to be suffering with an active, serious, significant mental health problem were prevented from deploying. And when they did that, they found that actually in the body of troops who did deploy, the rates of subsequent mental health problems were much lower. But I would argue that that's not really pre-deployment screening. That is good medical practice, which is to prevent people who are really quite unwell and therefore unlikely to cope with deployment from going in the first place. Certainly in the UK, we operate a medical employability system which would have people who were suffering with health conditions, physical or psychological, downgraded, and they would not be eligible to go. And so really the Warner et al. Paper is only doing what I would call good medical scrutiny of people's psychological health status before deployment, rather than actually screening them per se. Screening also can be applied after deployment, and I know the Australian forces make a lot of use of this through the Return to Australia psychological screen and the post-operational psychological screen, the RTAPS and POPs process. And many other forces, the Americans, the Canadians, the Dutch, and many other coalition forces make routine use of post-deployment psychological health screening in order to try and improve the chances that people who have mental health problems can go forward and get the right care. Actually, as it turns out, the US military, who screen all their troops, have funded a project at King's College London looking at post-deployment screening, because they themselves can't do it, because they would have to stop screening in order to do have a control group, which they can't do. But this study hopes to report actually later this year. We've been running it for just over 3 years now. But there is one published paper of the effectiveness of post-deployment health screening in terms of mental health screening. Now, for a screening process post-deployment to be effective, what you would have to do is to identify people who have a likely mental health disorder, for those people then to get an effective treatment, and then that would mean that later on their psychological health would have been improved by the process. So if you compare a group of people who are screened and then forwarded on to mental health providers to a group of people who weren't screened, it follows that the screening process should lead to the screening group having better psychological health outcomes, some six or so months later on than the control group who weren't screened. In the one published paper, which is published in JAMA, which is the Journal of the American Medical Association, a very impressive journal, the authors make it very clear that in the thousands of US troops screened, the ones who were recommended to go forward and get screening did in fact, in most cases, not agree with that recommendation and didn't get didn't get psychological help. The ones who did go forward, having been screened and did get psychological help, however, did worse psychologically 6 months later than the group who were recommended to get screening but didn't in fact take up that suggestion. So there was absolutely no evidence that the screen group did better. You could argue that there was evidence that in fact acting on the advice of the screener, screening was done using a paper and pen and also a face-to-face interview, that acting on the advice of the screener actually led to a worse outcome. Furthermore, in the control group who weren't advised to go and get any further help, some of them went and got help anyway. And really the paper, which is very well written, it broadly states in as clear terms as it can that the whole process of post-deployment health screening is pretty much a waste of time. Another problem about screening is that all screening has the potential to do harm. So in terms of psychological health screening, if you get screened and you get labelled by a healthcare professional or by a computer system or the like as having a mental health problem, but you don't actually get help, then you may begin to look back on that labelling as an important mark of the rest of your life. So when you go forward and you have problems with your spouse, or you don't get on at work, or you have difficulties of some sort, you may begin to believe that the screening process actually had labelled you and you should have got help. And therefore you may begin to believe you're more crazy than you really are. So the evidence about screening generally is that pre-deployment screening really very clearly cannot detect the propensity of people to break down after traumatic incidents, including deployment, and that post-deployment screening is not yet effective and actually has the potential to do some harm. Now, many proponents of screening would argue that the screening process itself does in fact provide an opportunity to talk about mental health problems and to try and destigmatise help seeking. And I would agree that that potentially could be a useful part of the screening process. However, in the UK, we have spent a lot of effort in trying to make sure that we give good post-deployment health briefings on at least a couple of occasions, backed up by managerial line manager, leader scrutiny of their troops' mental health, in order to make sure that for the first 6 to 12 weeks after coming home from deployment, people take mental health a lot more seriously than they used to. And we have evidence that troops who report having had a post-deployment screening do indeed do a bit better, although to be fair that evidence is rather weak. Where the evidence is stronger is in a study that we did looking at the impact of a specific form of post-deployment briefing called Battle Mind, which was a post-deployment briefing that originated in the US. We carried out a large randomised controlled trial of about 2,500 troops coming back from Afghanistan in 2009. And what we did is randomise about half of them by unit to receive the Battle Mind briefing, and the other half to receive a post-deployment standard briefing. Now, the Battle Mind briefing is one that in the US has been found to decrease the propensity of troops to suffer with post-traumatic stress disorder symptoms. But we didn't find that actually it had any effect on post-traumatic stress disorder symptoms in UK forces. We did, however, find that the Battle Mind briefing, which we adapted to cover alcohol more fully, given the problems that our troops have, actually did have a positive impact 4 to 8 months later on in terms of reduced binge drinking. So the evidence from our UK Battle Mind trial was that by tailoring a briefing to the specific needs of the returning force, you can in fact have an impact upon behaviours that you're trying to reduce, in this case binge drinking. However, it is fair to say that they're quite modest at best. So moving on to secondary prevention in a more formal way, This is to do with trying to detect symptoms at an early stage in order to make sure that they don't develop into formal long-term illness. And within the UK, perhaps the most important secondary prevention process that has been introduced over the last 15 years is the use of the peer support system trauma risk management, also known as TRIM. TRIM began in the Royal Marines in the late 1990s and is basically a process of training frontline troops, that's Marines, soldiers, airmen, sailors, who have no medical or psychological expertise, how to carry out a basic psychological health interview with their colleagues. And that is done on at least 2 occasions, a few days after the event, and again about a month later. And we know most people exposed to traumatic events or who recover from deployment are likely to experience some symptoms for a period of time. These are normal transitional symptoms, such as recurrent thoughts of a nasty event, not wanting to talk about it, being jumpy, all the symptoms of post-traumatic stress disorder if they were to persist and be severe and impairing. However, the TRIM interview allows a colleague, a buddy, someone who understands the context in which the individual has been through the traumatic experience, to sit down with them, to talk it through in a non-confrontational, non-medical way, but at the same time to try and spot the presence of 10 risk factors. The 10 risk factors are each scored 0 to 2, giving the TRIM practitioner, the person carrying out the risk assessment, the ability to score someone between 0 and 20, and the higher the risk, the higher the score, the bigger the risk. So after the initial TRIM interview, which is say done 3 or 4 days after the event, this allows the TRIM practitioner to gain an insight into how someone is doing. It's a proactive process, so you don't wait for people to come to you. The TRIM practitioner, it goes and seeks out the people who have been through challenging experiences and sits down and has an informal chat with them, covering the TRIM risk factors. And importantly, if the score is high, they don't just leave the individual, they ensure that they get good social support. They work with the individual to make sure that their team leader is aware of any difficulties, taking into account confidentiality, and also, most importantly, they provide some mentoring and advice and go back and see them again a month later. Now, a month later, most people, even those who are having difficulties at first, will be beginning to get back to normality, or may well indeed have done so. So the TRIM practitioner carries out a follow-up interview with the individual and again scores them between 0 and 20. And a score that was high initially but is low at follow-up interview is suggestive of a very normal recovery process. Whereas a score that is low initially and going up, or a score that is high and stays high, are both suggestive of a person who is not dealing well with the incident itself. And at this point, at the follow-up, the TRIM practitioner would be encouraging these individuals, helping them in most cases, to go and seek some professional advice from the unit medical officer, maybe a chaplain or padre if they prefer, or a mental health professional if one is close to hand. And the idea of the initial interview with the professional is not to start therapy, but is to undertake a proper assessment to determine what the individual's needs are. And at that point, the TRIM practitioner has handed them over, so has done their job. Now, the advantage of TRIM in many ways over older models, such as psychological debriefing, in which mental health professionals would have been flown in to try and assist with challenging incidents or the psychological consequences of, is that TRIM practitioners are geographically based within a unit. So whether they're in a forward operating base or on a remote part of an airfield on an exercise, they're part of the unit anyhow. And also, because they are non-medical, they should serve to reduce the stigma, because the individual doesn't have to report to a medical officer or their boss to speak about problems. They can talk to a trusted colleague who has had a certain degree of training. The TRIM training takes between 2 and 4 days to complete, depending on whether they're a TRIM practitioner or TRIM manager. And the job of the TRIM manager is to manage the TRIM team, to ensure they get the right supervision and to make sure that they stay refreshed and in date. We've carried out a lot of research on TRIM, and we certainly haven't found that this is psychological penicillin. It doesn't prevent everybody who gets traumatised from suffering mental health problems, but it does appear to be associated with an good organisational functioning. So we did a randomised controlled trial of TRIM on 12 Royal Navy warships and found that the warships that operated and used TRIM were much less likely to have evidence of poor behaviour in the terms of disciplinary offences than ships who weren't. We also find over time through other studies that TRIM can measure changes in psychological health. It appears to help mobilise social support. It appears to be quite acceptable to most personnel as a way of intervening with them. And in a study done actually with a British police force in the use of TRIM, the TRIM used after a major incident appeared to be associated with a less likelihood or a decreased risk of going long-term sick after being exposed to trauma compared to individuals who weren't trimmed. So overall, TRIM really appears to be a sensible, unit-led, peer-based system of trying to detect the early signs of psychological distress so that the individuals can be managed well within their unit by increasing social support and managing the pressure as they're trying to recover, and then monitoring them to make sure that if they do still have persistent problems, that they are encouraged and indeed assisted to go and get professional help, or at least professional assessment in the first place. We know that on an average 6-month tour of Afghanistan, where there might have been 10,000 British troops out in theatre at any one time, there were more than 1,000 assessments, TRIM interviews that went on. And what we know also over time, although it's very hard to link these two things, is that there is good evidence that in the UK Armed Forces that stigma rates on deployment and post-deployment have begun to decrease. Now they haven't gone away, but there has been significant positive progress in terms of troops being less likely to report stigmatising beliefs that would prevent them getting healthcare. And what we've shown is that as stigma has gone down, so the reliance and acceptability of TRIM has gone up. Hard to link those two things directly because of the complexities of linking those data and looking at other potential explanatory factors. But there is good evidence, I believe, and the science believes, that TRIM appears to be a credible, effective, peer-delivered support system that has a role in being a secondary prevention measure. Now, within the UK, the other main point about secondary prevention is to make sure that all the people who may come into contact with a distressed individual have sufficient psychological awareness to know what to look for. And this has meant that our medical assistants, so these are basically combat medical technicians or paramedics based within the military, that they have some psychological health training, and in the past they didn't used to have any. And also making sure that our padres and our line managers also have sufficient psychological training so that they can have a general awareness of what to look out for in individuals who have been through traumatic events. And then moving on to tertiary prevention, that is the effective treatment of individuals who suffer with traumatic stress-related conditions, be it after deployment or otherwise. Then, very much in accordance with the Australian and the US guidance, there is very strong evidence for the use of eye movement desensitization and reprocessing, and also trauma-focused cognitive behavioural therapy as being effective treatments for PTSD. Of course, one of the challenges is that many people don't come forward and get help at an early stage. That is the issue of complex post-traumatic stress disorder. Now, as yet, this is not an official diagnosis. It may well come into the International Classification of Diseases, Volume 11, when that comes out in a few years. But complex PTSD is usually a clinical condition in which someone has the symptoms of PTSD, but also has disturbances in mood and also in their views of the world. So much so that classic simple or classic PTSD treatments such as trauma-focused approaches or eye movement desensitization and reprocessing don't work very simply. Individuals who have complex PTSD have often had challenging childhoods, or they've often been through repeated trauma over a period of time, or particular traumas that, for whatever reason, has left them with a much more complex picture of PTSD. So individuals who suffer with complex PTSD often need a very considerable period of stabilisation, which involves psychoeducation, gaining trust with their therapist and the therapeutic environment, and often a number of other approaches such as narrative exposure therapy or compassion-focused therapy, which the evidence base for is perhaps less strong than it is for classic PTSD, EMDR and trauma-focused CBT. But nonetheless, there is good evidence for these sorts of approaches. The ideal is to get any individual suffering with a traumatic stress related condition to get to see a healthcare provider early on, so that hopefully complex post-traumatic stress disorder can be averted. But where complex PTSD does exist, then you need to ensure that there's a suitable period of stabilisation, often in some cases months of treatment, of stabilisation, before using a classic trauma-focused approach. It's probably worth mentioning that trauma-focused CBT also includes, in my view, approaches such as cognitive processing therapy, for which there is good evidence, also good evidence for that in terms of its use in groups as well, of veterans from the USA. And that there are a number of adjunctive approaches, such as brief eclectic psychotherapy, and I've mentioned also narrative exposure therapy as well. And of course, there is a role for medication, and medication can be used to treat comorbid conditions such as depression, and there is some evidence for the use of medication, particularly prazosin, in the treatment of some specific trauma related symptoms such as nightmares, and antidepressants themselves do have an effect on PTSD. But in terms of a definitive treatment, I think a trauma-focused psychotherapeutic approach between 8 and 16 sessions for classic PTSD is probably their most sensible starting point, and also the management of any risks to the individual or their family or indeed others, and any other comorbid conditions. Also, probably worth mentioning the fact that there is some good growing evidence that you don't have to deliver classic PTSD treatments on a once weekly basis over many weeks. A research trial carried out at King's College at the Institute of Psychiatry basically showed that you could deliver very intensive 4 hours of CBT a day over a week and get as good an outcome at the end of the week as you would have done of delivering a comparable number of sessions over a many-week process. There's also evidence that trauma-focused approaches can be delivered remotely using remote teleconferencing such as Skype or a similar package, or even there's evidence from the field of depression, certainly, that internet-based therapy, that is using instant messaging approaches, can also be effective for treating psychological conditions if they're delivered in a way that's consistent with a standard of trauma care, such as cognitive behavioural therapy. One of the biggest exciting challenges, I think, in the whole of the trauma field is about how we move organisations, including the military and emergency services and others, towards a place where actually people who have trauma-related problems can come forward at an earlier stage. So in the UK, for instance, we know that about 70% of individuals, whether they've served in the military or not, who have PTSD, don't get any help at all. So really, whilst there is good evidence about the right way to treat people who do have trauma-related mental health problems, the biggest challenge is in trying to get those people to come forward and get help in the first place. Well, I hope that's been useful for you. The aim of that has been to cover the broad brush outlines of primary, secondary and tertiary prevention of trauma-related and deployment-related mental health problems. This is an area which, if you're interested in the organisational guidance, is all freely available on the UK Psychological Trauma Society website, which is www.ukpts.co.uk, and you can download the organisational guidance document for nothing there. Thank you very much indeed.